And I invite Dr. Abraham Ittyachen to chair this session along with Dr. George Koshy.
First of all, may I thank AP Kochi for this chance. As most of you will agree that recent advances are important, but as also important are case presentations, because we get an experience, we get a chance to share our experience. And when we present these cases, we are not presenting just common cases, we are presenting rare manifestation for common cases, and also rare cases also we are presenting. So we have 2 cases, and it is of benefit for our PGs also, because as per the current NMC guidelines, they are supposed to present cases like this. So it's for that also I thank the API. Without wasting much time, we'll go to the discussion. First of all, I'd like to call Dr. Eldhose Babu to present his case. This case was admitted in Dr. George Koshy's unit. He will first give a small introduction before Dr. Eldhose presents his case.
Hello, yeah. Thank you for this opportunity to come and talk to you. This is a 23-year-old girl who came to us with polyuria and very high sodium, and we were working her up for her problems. If I tell more, I'll be saying about the case. So we have an interesting case with interesting pictures and images to show you. So over to Eldhose.
Department of Medicine, MOC Medical College, with a case of an unusual cause for hypernatremia. Case is that a 26-year-old female patient, known case of diabetes insipidus, came to the OPD for routine examination and found to have hypernatremia. There is no history of fever, cough, vomiting, headache, abdominal pain, loss of consciousness, cough, chest pain, hematemesis, hemoptysis, palpitation or syncope. On examination, patient is conscious and oriented, no pallor, icterus, clubbing, cyanosis, lymphadenopathy, pedal edema. Vitals are stable, pulse rate 75 per minute, BP 100/60 millimeters of mercury, SpO2 99% in room air, height is 140 cm, weight 37 kg. Systemic examination is within normal limits. Past history. She is an old case of recurrent craniopharyngioma, hydrocephalus, hypopituitarism, and status post near total removal of the tumor and removal of non-functioning VP shunt on August 2019. Coming to first consultation, it was on 17th of May 2015. Then an 18-year-old female patient with complaints of multiple episodes of vomiting, giddiness, and 1 episode of involuntary movement of both upper limbs, followed by confusion and drowsiness. CT brain plane study show intracranial space occupying lesion with calcification, and she was advised surgical excision of tumor. She had surgery for craniopharyngioma and placement of VP shunt on 6/6/2015. These are the CT images. We can see the lesions in the coronal section, sagittal section. The lesions have been seen. It's also visualized in the axial section in CT. Coming to second consultation, it was on 23/8/2019, and she presented with recurrence of headache and blurring of vision. She has features of hypopituitarism as well. She had CT and MRI brain which showed large residual and recurrent craniopharyngioma with raised intracranial pressure features. The CT head on 23rd August 2019 shows a large, well-defined hyperdense lesion with peripheral calcifications noted in the cellular, supracellular regions measuring 4.4 into 3.2 into 4.2 centimeter, and the lesion is causing mass effect on the lateral and third ventricles and compression of the interventricular foramen and foramen of Monro. And there is also mild prominence of left lateral ventricle. And then ophthalmology consultation was sought in view of blurring of vision. And then HFA was taken on 24/8/2019 and showed bitemporal hemianopia with greater involvement of the inferior field of temporal region, especially on the left side. It can be seen. Surgical treatment. Through a periocoronal minicraniotomy, interhemispheric transcallosal transventricular approach was chosen to reach the tumor, and near total excision was done using CUSA and micro instruments on 30/8/2019. CUSA is cavitron ultrasonic surgical aspirator. It's an ultrasonic device using low frequency ultrasound energy to dissect or fragment tissues with low fiber content. It is basically an ultrasound probe combined with aspirator device. When surgical treatment on the left side, a small tumor tissue was left behind as it could not be differentiated from midbrain or hypothalamus complex. Rest all tumors was removed and the ventricular catheter was found inside the parenchyma, was not working, and VP shunt was removed. Post operation, CT showed no hematoma. She had recovered well and was shifted to ward next day. However, on 5th day, she developed hyponatremia and became drowsy, shifted back to the ICU to correct electrolytes and to treat brain edema due to hyponatremia. She was given additional steroids and thyroid hormones. She improved and is being discharged on 13 September 2019. And a follow-up CT was taken on 2022. It showed cranioplastic defect in frontal lobe. Cella is widened with predominantly CSF density, lesion measuring 2.2 into 2.5 cm with peripheral calcification and hyperdense solid foci in the superior part. Superiorly, the lesion is indenting on the floor of third ventricle and causing minimal hydrocephalus. And the lesion is also abutting the optic chiasma and lamina terminalis and opacification of the base distance. Mucosal thickening of right maxillary sinus and the rest of the brain parenchyma, brain stem and cerebellum appears normal. These are the current investigations as on 4th of July 2023. These are suggestive of panhypopituitarism. Sodium level is found to be 162, which is suggestive of diabetes insipidus. Serum cortisol level less than 0.16, which is suggestive of secondary hypocortisolemia. ACTH level is less than 5, suggestive of secondary hypocortisolemia. FSH level is less than is 2.45, which is suggestive of hypogonadotrophic hypogonadism. LH level is less than 0.216, which is suggestive of hypogonadotrophic hypogonadism. TSH level is 1.174, free T4 0.66, and free T3 3.1, which is suggestive of central hypothyroidism. A 26-year-old female patient was admitted and evaluated. Routine blood investigation showed hypernatremia. She has presented with polyuria, polydipsia, hypernatremia, suggestive of central diabetes insipidus, and she was admitted for starting treatment for the same. Since she was asymptomatic, we attempted to stop her steroids replacement. However, 3 days after stopping, she developed significant biochemical and clinical features of hypercortisolemia with hyponatremia, which responded to IV steroids followed by oral steroids. Polyuria and polydipsia responded to tabminerin, and biochemically, she also had features of central hypothyroidism, for which we plan to start thyroxine replacement after 1 week in OPD basis. We also put her on estrogen and progesterone tablets to restart her periods, and serial monitoring of sodium done, and the values improved to 132. She was managed with IV fluids and other supportive measures. Presently, she is hemodynamically stable, symptomatically better, febrile, and the vitals were stable. Into craniopharyngioma. These are benign tumors that occurs at the base of the brain above the pituitary gland. It is a slow growing extraaxial epithelial squamous calcified cystic tumor arising from remnants of craniopharyngeal duct and or Rathke's cleft and occupying the supraocellular regions. Abrogenetic theory. This relates to the development of adenohypophysis and transformation of the remnant ectoplastic cells of the craniopharyngeal duct and the involuted Rathke pouch. Rathke pouch and the infundibulum develop during the 4th week of gestation and together form hypophysis. Rathke's cleft together with remnants of the craniopharyngeal duct can be the site of origin of craniopharyngiomas. Metaplastic theory. The metaplastic theory relates to the residual squamous epithelium which may undergo metaplasia, and the dual theory explains the craniopharyngioma spectrum. First one, adamantinomatous type to embryogenic remnants, adult type squamous papillary to metaplastic foci derived from mature cells of the anterior hypophysis, and there is mixed type. Adamantinomatous craniopharyngioma occurs at a younger age, commonly calcified, commonly cystic, and filled with cholesterol-rich fluid or soft necrotic fibers. A palisading layer of basiloid epithelial surrounds irregularly arranged cells that resembles the stellate reticulum of the epidermis. These nests may be solid but often form a complex trabecular network of microcyst. Bands of fibrous tissue weave between the nest of epithelial cells and around the cyst, and keratin nodules are commonly seen. This is the histopathological picture of the adamantinous type. Papillary craniopharyngioma, they are less common, occurs at an older age. Calcification is less common, commonly solid. Squamous epithelial nest that surround loose fibrovascular tissue rather than microcyst creates a solid tumor with pseudopapillary pattern. The keratin nodules are not seen. We can appreciate the pseudopapillary pattern can be appreciated in the histopathological picture. Clinical features. Headache. Visual symptoms in 20% of children can be seen and 80% of adult. Hormonal imbalance, short stature and delayed puberty in children, decreased libido, amenorrhea, diabetes insipidus. Behavioral changes due to frontal or temporal extension can be seen. Treatment option is mainly gross total suction and subtotal suction followed by radiation therapy. Thank you.
As I was saying, I wanted to be presented because we had some nice images of that unusual case, and it is an unusual case. This girl was already seen in neurosurgery few years prior, and she was referred to me by neurosurgery now because of this hypernatremia, and only after going to the history I realized she was drinking more than 10 liters of water and voiding so much per day, but she had become very used to that because that was her lifestyle. And then when we investigated, we realized that she had other features of hyperpituitarism also, for which we started treatment. But once we did all this, she became stable, and she was happy when her periods also came back after starting the hormonal replacement. I would like, anybody wants to ask questions or discuss, I'm ready to face. We'll go on to the second case.
Questions, we'll go to the second case. Dr. Nanditha, who is a second year PG, she will present. This is actually, like I told initially, unusual presentation of a common case. Now, I'm not going to the diagnosis. In the end, I'll summarize. When you see the case, you'll realize that it's a common case. All of us have treated, but it was a very uncommon presentation.
Good evening, all. I'm Dr. Nanditha, second year MD resident from MOSC Medical College, Kolenchery. Today, I would like to present my case of an 18-year-old female. She was a nursing student studying at Bangalore. She presented to our ER with complaints of fever and loose stools since 2 days. Fever was associated with chills and rigor. She also complained of 5 to 6 episodes per day of greenish, foul-smelling loose stools, which were non-blood stained. There was no history of any vomiting or abdominal pain. Past medical history. She had a history of appendicectomy done 10 months prior, and she was admitted at an outside hospital with similar complaints of fever, loose stools and vomiting 3 weeks back. And these are the investigations which were done there. She had thrombocytopenia with a platelet count of 62,000 initially at admission, which had recovered to 1.6 lakh on discharge. And she also had mild transaminitis with elevated ESR and CRP. Stool local blood was also positive. Ultrasound abdomen done there revealed mild splenomegaly. Echo was normal. Dengue, NS1 and IgM were non-reactive. Hepatitis A, IgM, HBsAg, HCV, HIV rapid tests were negative. Brucella, IgM and scrub typhus, IgM were also negative. The Vidal test done at the outside hospital was positive for Salmonella typhi O and H antigen, and after treatment and discharge, the titers had also fallen down. So there she was admitted in the medical ICU. 6 units of platelets were transfused in view of her thrombocytopenia. She experienced a chest discomfort during hospital stay. Echo done was normal. She was managed with IV antibiotics, ciprofloxacin and piperacillin tazobactam, oral doxycycline, steroids and other supportive measures. And she was discharged after 7 days of IP care to continue ciprofloxacin for 1 more week and other supportive measures. So this is a course in our hospital. She presented to our hospital with fever and multiple episodes of loose stools. Keeping in view the recent travel history and previous history of similar symptoms 3 weeks back, she was started on injection ceftriaxone 2 gram on day 1 of admission. Day 2, she continued to have multiple episodes of loose stools and had multiple fever spikes. Initial investigation platelet were normal, total count was 9,000 and it was neutrophil predominant except for an elevated CRP. Then day 3, she continued to have multiple episodes of loose stools and fever spikes, and there was a drop in the platelet count to around 1 lakh. An ultrasound abdomen was done on that day, which revealed hepatomegaly and a mild splenomegaly. By day 4, frequency of loose stools had reduced and even fever spikes had also came down, but now she developed complaints of abdominal pain and there was mild tenderness in the epigastrium. Platelets had further dropped to 50,000. So by evening her abdominal pain worsened. So we took a CECT abdomen which revealed a hepatosplenomegaly, mesenteric lymphadenitis and a bulky head of pancreas. And so keeping in view the platelet drop, we suspected a drug-induced thrombocytopenia due to ceftriaxone. So we stopped ceftriaxone and started her on injection azithromycin. In view of the pancreatitis, she was kept NPO and IV fluids were given and a start dose of dexamethasone was given. From day 5 to 6, abdominal pain was still persisting, but frequency of loose stools reduced and she had a few episodes of vomiting. The platelet count started improving after stopping the ceftriaxone, and by day 7 to 12, there was no further fever spikes and she was started on oral feeds by day 11. And finally, she was discharged by day 13. And as you can see, by day 6, the amylase and lipase levels had risen to around 3,000, and by day 8, they had started coming down. This was her temperature chart. Initially, she was having continuous fever spikes, but after day 5 to 6, and after starting azithromycin, her fever spikes had come down. This is a graph showing the platelet count. So initially, there was a drop in the platelet count by day 5, and after stopping ceftriaxone by day 6, slowly her platelet count started to improve. And this was the pancreatic enzyme levels, which had also came down by our supportive measures and other treatment. Then coming to other investigations, her ECG and chest X-ray were normal. Stool routine revealed bacillary exudate. Then malarial parasite smear was negative. Her Vidal test was positive for Salmonella typhi H antigen with a titer of 400, which was significant. But we also got a Brucella IgM positive result. But when we got the culture, blood culture yielded Salmonella enterica serovar typhi, which was resistant to ciprofloxacin and sensitive to ampicillin, ceftriaxone, chloramphenicol and cotrimoxazole. Urine and stool cultures were negative. So our final diagnosis is a relapse of enteric fever complicated with acute pancreatitis and thrombocytopenia, probably drug-induced secondary to ceftriaxone. And further, she was followed up. On day 21, she was symptomatically better. There were no further episodes of fever, vomiting or loose stools, and her platelet counts had also improved. So it's still there and evolving. Relapse of Enteric fever. It typically occurs after a week or so after stopping therapy. Up to 10% of patients develop relapse, usually within 2 to 3 weeks of fever resolution, and in association with the same strain type and susceptibility profile. However, relapse after 70 days has also been reported. When the blood culture becomes positive again, there will be high serum levels of HO and VI antibodies. Rose spots may reappear. Relapse is generally mild and shorter than the initial illness. And the incidence of relapse after treatment with fluoroquinolones is 1.5% and with azithromycin less than 3%, with broad spectrum cephalosporins around 5%. Rarely there can be second or third relapses as well. The next is antibiotic resistance in enteric fever. So initially in 1980s, it used to be treated with chloramphenicol, ampicillin and cotrimoxazole. But later plasmid mediated resistance came into being. Then fluoroquinolones became increasingly used. Then there was re-emergence of the susceptible strains to chloramphenicol and reduced susceptibility to fluoroquinolones due to mutations in the GAIR-A gene. Plasmid-mediated resistance to cephalosporins via extended spectrum beta-lactamase production has also been reported, but it is relatively uncommon. So, in a study from Delhi, resistance to ceftriaxone is around 16%, and it is least with azithromycin around 5.78%. So ceftriaxone, cefotaxime and oral cefixime are effective for the treatment of MDR enteric fever with failure rates of around 5 to 10% and relapse rates of 3 to 6%, whereas oral azithromycin results in defervescence in 4 to 6 days and the rates of relapse and stool carriage is less than 3%. So these are the antibiotic therapy in adults. As you can see in ceftriaxone resistant, in fluoroquinolone resistant cases, ceftriaxone and azithromycin is recommended, whereas if it is ceftriaxone resistant, meropenem or azithromycin can be considered for treatment. Then here we had a Brucella IgM positive as well as a Vidal test positive. So there can be false positives of Brucella IgM due to cross reactions, and this is due to the antigenic similarity between the lipopolysaccharide of the cell wall with other gram-negative bacteria. This can occur with E. coli O157 strain, Franchella tularensis, Yersinia enterocolitica, Vibrio cholera, and some Salmonella species. And mostly these are due to IgM antibodies. So detection of Brucella IgM antibodies should not be regarded as definitive in diagnosis and should be evaluated with appropriate clinical history and confirmed with another method such as Brucella agglutination assay, which is recommended by the CDC. And complications in enteric fever usually occur in 2nd to 3rd week, most common being GI bleed and intestinal perforation, commonly in terminal ileum. Then other atypical manifestations include meningitis, GBS, ataxia, ARDS, and one atypical manifestation is pancreatitis, which our patient had. Then hepatitis, hepatic and splenic abscesses, endocarditis, orchitis, osteomyelitis, DIC, HLH. Then certain neuropsychiatric manifestations such as muttering delirium or coma vigil. And rarely renal complications can also occur. This is a case report of acute pancreatitis associated with typhoid fever. In pancreatitis in typhoid relapse. Then ceftriaxone-induced thrombocytopenia, a few words. And in University of Oklahoma database, which tracks the number of drug-induced thrombocytopenia cases, only 6 reported cases of ceftriaxone-induced immune thrombocytopenia is present in literature from 1991 to 2013, and only 3 were confirmed with the presence of ceftriaxone-dependent antiplatelet reactive antibodies. And in 2 reported cases, the antibodies were against the GP2B3A subunit and the GP9 complex, resulted in accelerated platelet destruction and thrombocytopenia. This is a case report of confirmed ceftriaxone-induced immune thrombocytopenia. Here also, after starting ceftriaxone, the platelet had dropped, and once it was discontinued, the platelet counts had improved. So I'd like to conclude by saying enteric fever, it's still there and it's evolving. In our case, this was a relapse of enteric fever, and there was an emerging antibiotic-resistant strain of Salmonella typhi. And here we also had cross-reactivity of the serological test between Brucella and Vidal test in enteric fever. Then newer and atypical complications of enteric fever, and a case of ceftriaxone-induced thrombocytopenia. Thank you.
told you, this is actually a common case, and I think all of you will agree that along with tuberculosis, enteric fever forms the bread and butter of an Indian physician. This case actually, when the patient came to us, we approached it as a case of PU, because from the outside hospital, the discharge summary didn't tell what the diagnosis was. They had given so many antibiotics, and the only test positive was Vidal was positive. So basically it was approached as a case of PU. We started on ceftriaxone. By the second day the blood culture came. As you had seen, it was salmonella. Patient was happy. The patient's aunt was happy. Why I say the aunt? Because patient's parents were abroad in Saudi Arabia. Mother happened to be a nurse. So you can understand what the complications are when one of the parents is a nurse. So there was repeated calling. What is the diagnosis? What is the cause? So when we came, when we found that the culture had grown salmonella, we were happy. They were also happy. Fever also settled. But then by the third or fourth day, she started complaining of abdomen pain, and the platelets started following. So again, there was much problems. So because I have earlier experience with ceftriaxone and thrombocytopenia, I was fairly sure that that was the cause. I stopped that. In fact, the next day, the platelets started climbing. We had started on azithromycin. But then there was a problem of abdominal pain, and abdomen was tender also. It was actually kind of an acute abdomen. So we followed it with the CT, and before that itself, because we know that pancreatitis is a known complication, though a rare complication of typhoid, especially one with relapse, we did send for amylase and lipase, which were quite high. And CT also showed a very enlarged pancreas. Then of course, got the opinion of the surgeon, kept NPO, just conservative treatment. Within 48 hours, that also settled. Then because it was a case of initially as a PEO, that report of brucella was confusing because the titer was quite high. Again, we went back into the literature and realized that it could still be positive. So one by one, there were so many problems like you had seen here, but ultimately the end was good. After starting azithromycin, all her problems started settling, and by around late 13, she was discharged. She came for follow-up after 1 week. All the biochemical parameters are improved. So this is actually, this was a learning case for us, and like she told, enteric fever is still there among us. It is more than a disease, it is a social indicator of social progress. So that is why in Western countries we don't see much of enteric fever. Enteric fever will remain here, though we are all experts in treating enteric fever. We should realize that it will take different forms, evolve, antibiotic resistance, so many things. So I hope this experience will be of help for all of us who are treating enteric fever and will be treating. This has actually been sent for publication. It has also already been accepted. So it will shortly become in a published index journal also. So any questions?
It was partially treated outside hospital.
Yes, but there was no culture positive. It was just that Vidal was positive. And even in our case, I hope you had seen the Vidal, it was the H antigen that is positive. When that H antigen is positive, it actually means it's an anamnestic reaction.
Exactly.
It's not suggestive of...
all immunized patients also will have H antigen positive.
Yes. So it is not suggestive of...
Exactly. And you need to have a fourfold rise in titer, 1 week apart. And one more thing, like if patients have already been partially, you're lucky that you got a blood culture positive, but usually we go for a bone marrow culture. Partially
yes, exactly. That can still go.
So blood culture. And azithromycin has to be given 500 milligram twice a day, not a conventional dose of once a day. And many of patients do not tolerate such high doses because they develop diarrhea, because the proclinated drug.
Yeah.
So these are problems in managing enteric.
What duration can you give?
We gave for 6 days. IV actually if my memory is right, I think we give only for 2 to 3 days, and after once the fever settled, we converted it into...
And since it's a relapse, would you like to call the patient?
Severe thrombophlebitis also.
And this patient has relapsed, so would you like to call back the patient for a stool culture subsequently?
No. No, actually she came for follow-up twice, she was okay.
But you don't do stool culture?
No, we didn't do a stool culture, nothing, we did nothing.
Because
and the stool culture, I think it's more important if you have...
community.
If you have gallstones,
Yeah.
Otherwise, it is not much of.
Because gallbladder can be a reservoir of typhoid.
Yeah, that's the reason. But ultrasound CT didn't show anything.
How common is this thrombocytopenia due to
Cephalitis, no, I have seen that several times in leptospirosis.
But that will be due to the.
No. But then if the once that in leptospirosis, once you start treatment, unlike most other diseases, you can still have complications. And one of the complications which I have seen several times is ARDS. We know that it will come. I'm sure that those who have treated leptospirosis know that. As far as ceftriaxone is concerned, usually we never see a drop in ceftriaxone. It immediately starts climbing. It never comes down in leptospirosis. But in those cases where platelet doesn't come up, you have to suspect this ceftriaxone induced. And it is very well reported in literature, ceftriaxone. In fact, we had another case, because Sir mentioned I mentioned about leptospirosis, where after starting ceftriaxone, the bilirubin started climbing. In fact, it went up to 40 milligram percent, the bilirubin. Then 40, not 14, 40. Then only we thought, why is this rising like this ceftriaxone? Patient is always better. Urine color was getting yellow, and the relations were more concerned about that. Fever, everything had settled. Then again, I went back to the literature, and it's very clearly mentioned. Ceftriaxone can produce cholelithiasis and cholestasis and rise in bilirubin. We stopped that, and it came down to normal. In fact, that article also we sent for publication. It is already published in a PubMed Index journal. Yeah, that's what initially what we thought. But when bilirubin started crossing 30, 40 and all, we had second thoughts. It could be some other reason. But the moment we stopped that, actually the bilirubin came down. We stopped ceftriaxone and gave azithromycin. Ceftriaxone is a very useful drug, but there are some rare side effects which we should be aware of. That is probably part of relapse of Hendrick fever. It's well known. In fact, in Hendrick fever, pancreatitis, if you look into the literature, they mention both clinical pancreatitis and biochemical pancreatitis. Biochemical pancreatitis is very common in the sense that patient will not have any symptoms, but if you look at their lipase and amylase level, it will be high. It will be high. In our patient had both biochemical and clinical pancreatitis, because abdominal signs were there, and amylase and lipase were there, and on the CT, the pancreas was enlarged also. And of course, it came down gradually, the conservative line of management. If there are no more questions, we would like to wind up this session. I'd like to thank API for giving us this opportunity. Thank you, sir.